Good day, and welcome to your lecture on the post-operative phase. This is the third and the last phase under our perioperative nursing care. So we had a lecture on preoperative, intraoperative, and this one, your post-operative. Because of this nursing diagnosis, your plan will be to ensure that our patient would have adequate lung expansion and respiratory function. And this would be evidenced by your O2 saturation, respiratory rate, airway clearance, okay, all those things. Heal without post-wound complication or post-op wound complication as evidenced by the absence of the pus in your wound. Experience alleviation or reduction of pain associated with surgical wound as evidenced by their verbalization of the tolerance of pain, their ability to ambulate despite of being on 24 hours post-op, meaning they can tolerate the pain that they are having, okay? Then, implementation. For implementation, as I have mentioned, your proper or your primary opportunity or primary priority, is your airway patency. Okay, you always assess for the patency and you need to promote gas exchange. So your interventions are inclined towards this. Regardless of the procedure of your patient, you always perform your ABC assessment, meaning you always start with airway before you go to breathing, before you proceed to circulatory assessment and interventions. Maintaining circulation. For you to maintain proper circulation for your patient, you need to assess the vital signs of your patient. That would include the pulse, the blood pressure, and the respiratory rate. Hypotension, arrhythmias, and shock should be immediately managed because you don't want complications to occur before you would manage this type of problems. To maintain fluid and electrolyte imbalance, okay, or balance, you need to have a balance between the intake and the output. As previously mentioned, you need to check on the amount of fluid loss during surgery, the amount of urine of your patient, in contrast to the input that your patient had. So that would mean the IV fluids that your patient had, the blood products that your patient had. Okay, also you need to know the IV fluid of your patient. Is this an isotonic IV fluid, hypotonic IV fluid, or hypertonic IV fluid? You also need to know the drainage and the amount of the drainage. May that be the amount of drainage from your catheter or from your wound drainage, which would even include your Hemovac, your JP Pratt, or your Jackson Pratts. Okay, you need to take note of those things because those are still fluid losses of your patient. If your patient is attached to NGT with drain, you need to measure the contents of the drain for you to know if adequate fluid balance is being maintained by your patient. Okay, maintain respiratory and circulatory function. This will be important, so you need to make sure that the signals are always up for safety purposes. You need to turn your patient every 2 hours. Other than the benefit class that your turning would prevent the occurrence of your pressure source, your turning also helps on the respiratory and circulatory functions of your patient. Okay? On the other hand, you might be wondering on how to deal with a patient with hypothermia because in the operating room, the patient's room or the patient's environment is cold. Other than that, your patient have had anesthesia, meaning some things are down. Okay, so caution. You might want to use heating pads, heat lamps, and then cast dryers. But if you are using this among patients who are unconscious or who are recovering from anesthesia, think twice. Okay? Some hospitals would not already allow for the use of your heating pads among patients who are unconscious, among patients who have diabetes and other skin sensation problems. Why? You are exposing your patient to the risk of having burns. Okay, that's why you need to be very extra cautious about that. Next, maintaining comfort. So you can give narcotics. Narcotics for incisional pain. Just take note that your narcotics could cause respiratory depression. That's why it should be given with extreme caution. Okay, it should be given with extreme caution. Other than that, repositioning your patient every 2 hours would promote comfort because of the alleviation or decrease of the risk of formation of your decubitus ulcer. You also need to check the dressings if it is soak and constrictive. Constrictive dressings class are not recommended because your constrictive dressings could impinge the blood flow. Okay, it could impinge the blood flow and hinder the healing process of your patient. Okay, relieve anxiety. To relieve anxiety class, you need to reorient your client. Okay, reorient your client. Remember that your client might just have woke up after surgery, so she needs reorientation where she is right now. Okay, she also needs reassurance class that she is not alone. You need to inform that the operation is over and that recovery from anesthesia is going on. You need to explain procedures being carried out even if the client appears not to be alert. Okay, class, they may appear not to be alert but they are conscious and cognizant of what you are saying. So to allay their anxiety, you need to explain to them the procedures that we are doing. Do not overlook the routine hygiene such as mouth care, skin care, etc. Oftentimes, class, if you're assigned in the PACU and the ICU, your tendency is just to deal with the tubes and the connections that your patient have. But here, class, in this case, you are being reminded that you need to take care of the hygiene of your patients, including mouth care and skin care. Okay, post-operatively, class, mouth care is strongly needed because, okay, there might be pooling of secretions there which was not removed properly during suctioning. Now, criteria for discharging the patients from the PACU. The patient needs to have stable vital signs, adequate respiratory and circulatory function. Also, the client is awake or easily aroused and call for assistance if needed. Other than that, if your patient have had regional anesthesia, you need to check for the presence of motors, meaning the patient is able to move, plus the partial sensory return on all anesthetized area. Okay, so there should be motors, there should be movement, plus partial return of sensation on that part of the area which was previously anesthetized. Okay, for the wound drainage, you need to make sure that the wound drainage is minimal to moderate. Urine output again of 30 ml per hour, and then the return of your gag reflex, cough reflex, and then your swallowing reflex, because this would indicate the functioning of your GI tract. Hence, class, minimal risk for aspiration. That's why we need to assess for that. Care for clients who are for direct discharge. Take note that there will be clients that after being admitted in the PACU after surgery, they might be discharged directly. Okay, some of examples of this are your same-day surgery and ambulatory surgery. Okay, take note that if you're having these patients, they need both verbal and written instructions. Do not say that verbal instructions would suffice, because their tendency will be by the time that you're instructing them, they will just say, yes, yes, I understand. But by the time that they will be at home, they already forgot what you have told them. Okay, promoting home and community-based care is also important, and teaching patient self-care and also the continuing care instructions. That would include how to perform the dressing properly, what are the medications that he or she needs to take, when is the best time to report back to the physician. That might be after 7 weeks or 14 days. Okay, or 7 days to 14 days, I mean. They also need to know when is the time that they need to go back to the hospital in case there is an emergency. What is an emergency in terms of the case that she has on her wound post-operatively? If the patient will be transferred in the accommodation such as an inpatient department, the same apparatus as being prepared in the PACU will be needed by the ward nurses to be prepared. IV pole, BP apparatus, a basin or your kidney basin, and then your tissues, suction equipment, and then oxygen. Post-operative assessment. Post-operative assessment is very important. That includes the neurologic status of your patient. On the neurologic status, you are assessing the level of consciousness of your patient, the ability to follow command, sensation, and then the ability to move extremity, especially if your patient had regional anesthesia. This will be very important. After that, on the respiratory status, you'll be talking about the patency of the airway, respiration, breath sounds. You need to check for the presence of breath sounds. Absence of your breath sounds would indicate atelectasis or collapse of your lungs. You also need to note the character of your breath sounds to indicate if there is presence of wheezing or presence of stridor, which are signs of respiratory obstruction. You also need to check if chest expansion is bilateral. You also need to check the patient's position to facilitate ventilation. If your patient would need to sit just to breathe properly, you might explore that your patient is having respiratory problem. Ability to deep breathe and cough. These are important. Deep breathing is important for us to address lung expansion. Coughing is important both for lung expansion and also for the excretion of, or secretion, of your secretions. Okay? Or excretion of your secretions. And then, class, they should be able to reach the call cord whenever they need it. Okay, or what you commonly refer to as your call light. Now, you also need to check the BP and temperature of your patient, pulse, rate, and strength. For the strength of the pulse, you need to check the strength of the pulse distal to the limb of surgery. So if the operation is here on the right hand, you need to check for the presence of the radial pulse. You need to assess for the strength of that pulse. Any weakness on the pulse here might indicate that there is problem, okay, on the arteries on this part of my body. Next, you will have capillary filling or your capillary fill time, which is your less than 2 to 3 seconds. Then for comfort, you need to check for the presence of pain. If there is pain, you employ your cold spa assessment. Start from character, onset, location, duration, severity, precipitating and aggravating factors. Now, nausea, vomiting should be addressed. Warmth should be given to your patients with the use of your blanket. And then the patient's position of comfort should also be addressed. Now, safety is also very important. That's why side rails should always be up. For mobility, you start with their ability to turn self and ability to do leg exercises. You do not hurry your patient such that in the first 2 hours, they will be standing and walking. For the mobility, you can content yourself first by the turning of your patients, especially if the surgery lasted for 4 hours, before you would ask them to rise and then walk around. Okay, monitoring systems, that includes your call bell, should be properly connected and functioning. Intravenous fluid, you should be aware of the rate, the amount in bag, and then the patency of the tubing. For your dressings class, you need to monitor the drainage in case there is presence of frank bleeding, drainage system type, if it is open drainage or closed drainage system, patency of the tubes, okay, because patency of the tube is one of the reasons for under documentation of your drainages. Some would perceive that, oops, he has no output, but whereas the problem is that the tube is not patent. And then connection to collection containers. The purpose is for you to accurately collect the amount of the substance being collected, such as your drainage. And then you also need to make sure that the clean or sterile technique is being employed in such a way that the system, okay, will not be open, not predisposing the patient on infection. You also need to note the character and amount of drainage. The character and amount of drainage class will be part of your nurse's notes, okay? Unless there are forms wherein this one is documented. Nursing process is applied on the post-operative phase. Assessment. You need to perform review of systems. So you need to pay particular attention on the systems that has been affected during surgery. Other than that, you also need to perform a comprehensive assessment. Post-op respiratory assessment would include open airway, pulse oximetry, and then check for opioid use. If you can recall, your opioid is expected to lead to respiratory depression. That's why you need to check if opioids were used intraoperatively. You also need to check for the use of PCA or patient-controlled analgesia, epidural analgesia, spinal analgesia, which is also referred to as intrathecal. These types of analgesics are used for post-operative pain. Now, it may contain morphine, fentanyl, or hydromorphone. For this type of anesthesia, take note that it may render the patient to be pain-free for 12 to 24 hours. So this is an image showing the use of your PCA or patient-controlled analgesia. When I talk about patient-controlled analgesia class, okay, there is a continuous dose being administered to your patient, let's say for example, every 2 hours or every 3 hours. It is referred to as patient-controlled analgesia because by the time that the patient is feeling pain, they just need to push the button and then that button will trigger for the release of additional medications. There is a ceiling dose for your patient-controlled analgesia, meaning it will not be unlimited on the part of your patient. There will be a time that the maximum dose will be reached. Now, on prevention of venous stasis. So when I say venous stasis, your venous stasis has a tendency to lead towards deep vein thrombosis. So you need to avoid dependent positions. Bed exercises, whether passive or active ROM, is recommended. Anti-embolic stockings to allow adequate venous blood flow or venous return is recommended. Sequential compression stockings may also be used. And then, of course, ambulation is the best remedy to prevent your venous stasis. But again, as I have mentioned, you do not immediately push your patient to ambulate, okay? Especially within the first hours post-operatively because of the risk for fall that may come from the use of anesthesia. Post-op skin assessment would include observing wound healing. Take note that after OR to day 2 or even up to day 3 or 5, you need to assess for the presence of inflammation and infection. Take note that there will be redness, if there will be pain, swelling, and warmth. These are signals that there is something abnormal occurring on the wound of the patient. Take note that reddish wound is expected, especially on the first 2 days post-operatively. However, if this wound starts to become smelly, starts to produce pus, you need to be mindful for the presence of infection. Other than that, you need to note that the skin is held together by blood clots and tiny new blood vessels. That's why pressure is avoided, and you need to make sure that splint is being done whenever your patient will be exerting effort towards the suture site. Okay, what do you mean by that? Remember, the wound healing mechanism takes place, inflammatory processes take place, okay, in order for the skin of your patient and other organs there to be healed. That's why pressure is avoided, splint is recommended. Also, you need to care for the surgical drains of your patient. Surgical drains, class, are not only intended to drain the fluids, but it's also intended to decrease the pressure inside. Okay? Because if there will be a lot of fluids inside, class, there will be an increase on pressure. Okay? There will be an increase on pressure, hence hindering your wound healing process. Now, managing normal temperature is also important. Take note that intraoperatively, your patient might have blood loss. Post-operatively, it increases the risk of your patient for hypothermia. That's why warming blanket is recommended. Okay, warming blanket is recommended. If your patient is having signs of hyperthermia, class, we need to watch out for infection. We need to watch out for infection. Or maybe you need to watch out for the recurrence or late onset malignant hyperthermia. Okay? Late onset malignant hyperthermia. Now, for the post-op GI assessment, class, you need to check for the presence of nausea and vomiting. You need to auscultate for peristaltic sounds because absence of your peristaltic sounds may indicate paralytic ileus. Okay? As the term implies, paralytic ileus, paralysis of your intestines or your small intestines. NGT insertion might be needed if your patient is having risk for nausea, vomiting, and there are several gastric contents that might cause aspiration. If your patient is also having nausea and vomiting, class, your patient might need gastric rest. And your gastric rest is done by NPO. Okay? Your gastric rest is done by doing your NPO. Now, turning and ambulation is also being done. So, your turning and ambulation would induce your gastrointestinal tract movement. That's why, class, if you can notice in the hospital setting, if your patient is not able to pass flatus, the tendency for us to instruct your patient is to turn to sides. We would instruct your patient turn to sides from time to time so that it will induce flatus production. Okay, because, class, this triggers gastrointestinal movement. Diet post-op. Remember that your patient had been placed on NPO, okay, pre-operatively, okay, and of course, intraoperatively. You do not right away push your client to have the regular diet. Your patient needs to have clear liquid before they go to full liquid, before they would have soft diet and regular diet. Now, I would want you to read on your books on what are the food qualified for clear diet, full liquid, soft diet, and even your regular diet. In terms of urinary assessment, you need to watch out for the possibility of urinary retention. Your urinary retention, if your patient is not catheterized, will be manifested by your distended bladder. Okay? Your urinary retention is caused by anesthetics, administration of your anticholinergics, and even your opioids. For this patient, your best intervention is still ambulation. And you need to carefully monitor the patient because your distended bladder may have neurologic-related complications. Okay? Other than that, you might need to administer fluids to these patients. Also, client is expected to void within 8 hours after surgery. So you need to stimulate the client to void. That may be done by ambulation, or that might be done by turning on the faucet such that it mimics the sound of urination. Straight catheterization may be done if the urinary functioning of your patient is not yet back and then he is experiencing bladder distension. Okay, bladder distension. Post-operative complications that you need to watch out for. Deep vein thrombosis. So your deep vein thrombosis is categorized by or characterized by pain or cramping in the involved calf or thigh, redness and edema of the entire extremity, slightly elevated temperature of the skin there that might see as warmth, and then you will have your positive Hohmann's sign. Okay, when I say positive Hohmann sign, that is pain on the lower calf experienced by the time that there is dorsiflexion of the foot. So again, Hohmann sign is triggered by the dorsiflexion of the foot. In this case, class, you need to watch out for the anticoagulants, or you need to give, anticoagulants to prevent further thrombus formation. For the pain experienced by the patient, you might need to give analgesics. You also need to perform prothrombin time, PTT, and then clotting time. Okay? PT, prothrombin time, partial thromboplastin time, and clotting time. For us to know the bleeding parameters of your patient, because we are starting them on anticoagulants. You need to maintain the patient on strict bed rest, and you need to keep the affected extremity at or above the level of your heart. Okay? You need to keep affected extremity at or above the heart level. That is to allow for venous return. You are supposed to apply, okay, thigh-high anti-embolic stockings or your TED stockings or even your ACE wraps. However, you need to advise your patient that they are not supposed to rub or massage the area. They are not supposed to rub or massage the area. That would dislodge the thrombosis, leading to another complication, which is your pulmonary embolism, which is life-threatening. Okay, pulmonary embolism, characterized by sudden onset of mild to moderate or even severe dyspnea, presence of chest pain, diaphoresis, anxiety, restlessness, rapid pulse, respiration, dysrhythmia, cough, and cyanosis. For this patient who have had these signs and symptoms, you need to position the patient on bed rest and keep the head of bed elevated. O2 at 100% should be given. IV fluids will be given. Anticoagulants or even thrombolytics are administered. Administer analgesics and sedatives. Sedatives there are intended to decrease the oxygen demand of the body. And then frequent assessment and recording of the vital signs and the general condition of your patient. Pneumonia. Pneumonia post-operatively is caused by the secretions or by the pooling of secretions because of the inability of the body to secrete the secretions, okay, or to expel the secretions. So you need to make sure that the head of the bed is elevated. You need to make sure that there is a sputum specimen for culture and sensitivity because your patient might be having productive infectious cough. Also encourage the client to do your turning, coughing, and deep breathing exercises. All of this, turning, coughing, deep breathing exercises would help on lung expansion, would help on the mobilization of your secretions. Administer oxygen as ordered, and then you need to assist your patient in the performance of your incentive spirometry, even in your intermittent passive pressure breathing, and then your nebulizer. Okay? You need to monitor for the presence of chest pain. You need to monitor for crackles and wheezing. If your crackles and wheezing will continue to persist, that would indicate a progressive infection and even congestion on the part of your patient. This is why it is important, class, for us to perform proper suctioning when it comes to our patient to prevent this kind of complication. Now, constipation. Your constipation is characterized by inability of your patient to defecate after the surgery in this case. Now, you need to check for the return of normal peristalsis. You need to auscultate the bowel sounds of your patient. You need to check for the presence of flatus. And after that, class, the key for this to prevent constipation is still your ambulation. You need to facilitate such that your patient would have 2.5 to 3 liters of fluid every day. If there is still no bowel movement in 3 to 4 days, a suppository or enema may be ordered by the physician. Again, suppository or enema may be ordered by the physician. But class, it does not mean that if your patient was not able to defecate within 1 day post-operatively, you will say already that your patient is having constipation. Take note, your patient was not able to eat anything. So you would not expect them to be able to defecate on the day immediately post-op. Okay? That's why it says that 3 to 4 days post-operatively, that's the time that you can consider it as constipation. Dehiscence. So dehiscence is the opening of your wound edges. The best nursing responsibility that you can do is reinforce the wound with a butterfly dressing. Okay? Butterfly dressing. And then binders are recommended when ambulating. You also need to inform the physician about this because the physician might need to assess if another suture needs to be done, okay, to minimize the risk for infection. On the other hand, if the wound edges has already part, okay, slowly, and there is sudden gush of profuse pinkish serous drainage, this is already evisceration. So you need to cover the wound with sterile dressing. You let the client maintain bed rest with the knees bent. The purpose of the bending of your knees there, class, is to ensure relaxation of the abdominal muscles. And then you need to prepare for an emergency surgery, provide emotional support to your patient, and reassure that help is coming because you will be calling for the physician. So here are some of the nursing diagnoses that you can have for your patients post-operatively. And in evaluation and discharge planning, you will be preparing your patients for home care. Okay, you need to assess the home setting of your patient. You need to have verbal again and written instruction for the home modifications of your patient. You need to identify the needs of your patient for dressing changes and personal hygiene. Important points for client teaching is how to prevent infection, how to properly clean the wound, how to care for the surgical wound, what will be the appropriate diet for wound healing. That would include your vitamin, okay, your vitamin A class, your vitamin C, your vitamin D, your vitamin K, and even your protein. What are the drug therapy needed? So as I mentioned, your pain medications will be needed. Progressive activity is recommended. So hence advise them that post-operatively, they cannot just resume to their daily activities without gradually, progressively increasing it. Proper hand washing is still the best way to prevent your infection. Other than that, you need to have psychological preparation. That would include emotional support from the family and allow them to express their concerns. You might need to refer your patient to other agencies that can help on dressing changes, activities of daily living, and even meal preparation. Especially class if your patients are living alone, okay, or is living alone. This is for your post-operative nursing care. Once again, this is Porks, and I thank you for your kind attention.